being here.
Good evening. It's wonderful to be here. I absolutely love the opportunity to share what we do with the community. The thing about substance use disorder is it's very often misunderstood. It can be very counterintuitive in terms of anytime we see something where it looks like someone's acting against their own best interests, or any type of disorder where compulsion is involved. It can be very challenging. So we're looking forward to tonight's conversation. We want to talk not just about some of the markers of substance use disorder and addiction, but we want to talk about some of the dynamics of recovery and how to support those who are affected. I know in these types of community presentations, there's almost always a mix of people tuning in. Some people may be in the field looking to just sort of learn a little bit more. Some people may be personally affected or have family members that are affected, or just wanting to educate themselves on some of the options with health. So we're going to really make sure there's a little bit of something for everyone here. Some topics we're going to kind of keep at a very high level. Some we're going to go a little bit deeper into. So together, really kind of our goal here is to provide a stigma-free, practical overview of substance use disorder, how it impacts everyone, and what recovery really looks like. I do want to make sure that there's time for questions and answers at the end. In addition to working in the Recovery and Wellness Department as the manager, I also teach social work as an adjunct professor at Ramapo College. I'm on a number of advisory boards throughout the county, really with the goal of just spreading this information and doing whatever we can to address substance use disorder and promote recovery in our communities. So we'll start with the question, what is substance use disorder? The kind of official definition, paraphrasing here, is it's a chronic relapsing brain disease characterized by compulsive substance use and continued use despite harmful consequences, and then also long-lasting changes in the brain neurologically. It impacts how someone can think, feel, and act. It is a medical condition, and we do want to point out it's not a moral failing. You know, throughout history, and sometimes we like to say since the first sort of early man found a plant that made them feel a little different, this has had the potential for an issue. For pharmacology and human physiology haven't always played well together. And so what we really want to look at is the fact that throughout history, there have been a number of different models to conceptualize substance use disorder. In some cases, and at some points in our history, we went with a substance model, which kind of blamed the substance or characterized the substance as bad or harmful or evil. You know, we ask a question like, well, is fentanyl bad? And now with some of what we've seen in the news cycle, I think most people would sort of jump to say, well, it's bad. But with something that has a legitimate pharmacological use, it could be very beneficial in appropriate treatment, like post-surgery and for end-stage cancer pain treatment when used appropriately. So it's not necessarily the substance itself. And so then a lot of times we would go into the moral model, and that's where certainly around turn of the century and the early 1900s really was where there was like a lot of stigma, a lot of someone who had substance use disorder was just sort of attributed as a moral failing or lack of fortitude or willpower, all of these types of things. And, you know, the way we think about and talk about substance use disorder really changes the way we react to it. And so I just wanted to put a little note in here that language matters. And even some terms that are very commonly thrown around, like, well, someone's clean, or they're an addict, or they went to detox. When you think about the subtext there, even substance abuse, we've moved away from that. I know it's still very, very commonly used. We want to move towards, because when you think of abuse, that has a lot of these negative connotations. Clean suggests that if you're not clean, well, then you're dirty. And detox has that toxic connotation. We want to move towards more compassionate and understanding terms like someone maybe who's sober or in recovery, or a person in recovery. And instead of detox, with things like withdrawal management or alcohol use disorder, opioid use disorder. The way we speak about these things and conceptualizes it really changes the way we approach it, address it. And so that's just my little note on that. We're going to get into a little bit of the nuts and bolts science part of this here. We're going to talk a little bit about how addiction affects the brain. When you think of all addictive substances, or all substances that, because not everything is going to create the potential for substance use disorder. There are plenty of substances that people can take consistently and they don't have the same effect. But what we would call addictive substances affect the brain's reward system. And this is powered by a chemical called dopamine. And this chemical helps us experience pleasure and motivates us to repeat behaviors that are essential for survival, like eating, bonding with others, exercising. All of these positive pro-social healthy activities are designed to, we're hardwired as human beings to have a release of dopamine. Now, when someone uses drugs or alcohol, these substances trigger a much larger and faster surge of dopamine than the brain could normally create on its own. And that's a lot of times what people refer to as the high. But the secondary effect of that is because the brain is now being forced to do things like that, it creates this what we call neuroplasticity. The brain is forced to kind of have some of these pathway changes. And really what this does is the brain, at a very top level, the brain remembers this feeling and begins to associate the substance with pleasure, and with just kind of something that needs to be repeated. And over time, it can start to reduce its natural dopamine production, or even sometimes the number of dopamine receptors. And what this does for the person is makes it harder for them to feel positive things from everyday activities. It could leave a person feeling flat or depressed. And we hear that reported a lot of the times with our patients. So the long and short of that is that the continued use over time, it does affect the brain. And that's part of why treatment can take a little bit longer, is because when someone is working in or using substances at the level where they would start to develop substance use disorder, that's really kind of pushing it forward neurochemically. Recovery doesn't have that pharmacological push behind it. And if you think about it, it's a lot easier to go down the slide than it is to sort of climb back up. Because when you're using talk therapy and reassociating some of these things with behavioral therapies, that does generally take a lot longer to repair or reestablish some additional pathways. Now, as far as how decision-making is affected, it's one of the things where anyone that's worked with someone or knows someone who has had a substance use disorder, it can be very challenging to talk about it, to address it, because it really is so counterintuitive. I mean, if someone were to remember, the definition we use is that someone continues to use these substances despite persistent negative consequences. And so sometimes it's like, well, why is someone doing that? Or why would they do that if they know what's going to happen, or if they know their family's going to be upset, or someone's going to leave them, or they're going to have worsening legal consequences? Why would someone do that anyway? And so if you think about it, substance use affects multiple areas of the brain. Prefrontal cortex, the basal ganglia, these are regions that control motivation, emotion, stress, and decision making. And as these areas become disrupted, people can start to feel strong cravings when exposed to triggers. There's a whole section of social science that developed called of course, now I'm blocking on it, I'll get back to it, behavioral economics. And that really looks at things like how people respond to gambling and sunk costs, and why people behave in ways that really don't seem to make a lot of sense. And when you start to understand some of these things, it really looks at how people relate to impulses, and how once someone is triggered, how the brain can light up and really start to alter some of this decision making. And I think a good analogy is if you look at addiction, like turning up the volume on your favorite song until it's so loud that your ears adjust and you stop hearing all of those softer sounds. In the same way, substances can overwhelm some of the brain's normal signals, and it makes it harder to operate in the absence of that. Now, I want to go into some categories of substances. And if there are more, I did include some references here with some of the articles that really do a great job of making some of this neurochemistry stuff very, very accessible. You certainly don't need a science degree to be able to really kind of learn these mechanics and understand how it relates to some of these behaviors. So for those that are interested, I do have those links at the end. Looking at some of the categories of substances, I think this is helpful to get a quick baseline on this. Alcohol, when you look at the short-term effects, we've all seen, either in person or in the movies, or what someone looks like when they're drunk. That's essentially what we look at as impaired coordination, judgment. Long-term use for health issues it could contribute to liver disease, cardiovascular issues, and neurological problems. And when we look at alcohol, it's interesting because a lot of times, because it's so accessible, because it is sort of advertised, because it is sort of seen as something that is very commonplace, from a withdrawal management standpoint and from a medical standpoint, it's actually one of the more physical, harmful, and actually one of the most dangerous substances to withdraw from. When you look at withdrawal for something like heroin or fentanyl, those withdrawal symptoms can be extremely, extremely uncomfortable and disruptive, but they might not necessarily be fatal. Where when we have some of these withdrawals from certain prescription medications like benzodiazepines and alcohol, they could cause seizures that could actually cause fatal complications. And we just generally don't think of it with something that's sold or promoted so commonly. Prescription medications, when you look at opioids, those are prescribed for pain, but they do have a high potential for addiction. Also for overdose, this could be something like oxycodone, hydrocodone, fentanyl. And those would be some things that in the early stages of the opioid epidemic were prescribed at much higher levels. We were able to regulate that, but really at that point, it really was a little bit too late. And with the regulation, people, what they found was were looking to either buy them on the street, or that kind of opened the door for some of the additional heroin that came through. But for prescription medications, the opioid classes would be those medications. Benzodiazepines, these are used for anxiety. These would be like a Xanax, a Valium, a Klonopin. A lot of times they're prescribed for sleep or anxiety, but there is a potential for dependence. And a lot of times what we found is for people who have a high baseline anxiety, if they're not working in therapy sometimes to develop their own coping skills to manage intrusive thoughts or anxious feelings, and they become reliant on this, when you step away from that, the rebound anxiety from that can be very, very disruptive. I've worked with patients who they're so committed to getting off of this, but the transition to that, they feel so anxious and fearful about everything. It can be very, very uncomfortable. So there is a place for some of these prescribed medications. This is not to say that these are bad or inappropriate medications under all conditions, but they do have that potential for misuse and leading to dependence. Illicit drugs, cocaine would be a stimulant. That leads to that euphoria, but can cause heart and respiratory issues. Methamphetamines is another stimulant. Increases a lot of energy and focus, but it can cause dental issues, skin sores. It can lead to psychosis as well. Heroin, what's interesting about heroin is that really fueled a lot of the second and third waves of the opioid epidemic, but it's really been replaced by a lot of synthetic substances, and a lot of these are much stronger. And what we're finding is a lot of people who come into treatment thinking that they're using heroin, they don't even test positive for that. They only test positive for some of these synthetics. It's mostly fentanyl out there that's being sold as heroin. Or what we've seen recently is a transition to people who in the past, in the early, like maybe mid 2000s, I would say, would identify as heroin users, actually are now starting to identify as fentanyl users, and they're going out and seeking that fentanyl directly. Cannabis, this alters perception, mood. Cannabis is interesting because it has multiple classifications. It can serve as a stimulant, a hallucinogen, and a depressant, depending on how it interacts. This is something that's really there's been a big focus on cannabis treatment recently, because with the legalization, when you look at early cannabis, it was a much different type of a substance. When you look at sort of a rolled joint or something like that throughout most of the time that cannabis was being used, and while it was illegal, this was something that would be a much lower purity percentage of concentration of the effective chemical THC could be 7%, 11%, something like that. And now what we're seeing with some of the much more refined items available in the dispensaries, we're seeing percentages up to 80, 90% in some cases. And we really don't have a lot of long-term data on how that would affect people at that potency. And so I think that this is something where, similar to alcohol, once it becomes normalized, it's really important to sort of maintain and look at the difference between what is this doing for someone, what is it doing to someone. And just using alcohol as an example, there are plenty of people who have absolutely no problem having a glass of wine with dinner, and that's pretty much it. They're done. They might not even finish it. Other people, for a lot of different reasons, it may develop over time to the point where that turns into 2, 3, 4, 5, or some people who just everyone's body reacts differently, and where they would develop that dependence on it a lot quicker. So similar with cannabis, this is something that we do kind of want to keep an eye on and see what some of the long-term effects of those. Inhalants we don't really see as much. That would be things like whippets or sniffing propellants from some of these other types of things. You can get a short-term euphoria, but the toxicity and the damage associated with that can be pretty devastating as well. Other types of substances would be steroids or designer drugs. The designer drugs would be things like ecstasy. Issues with some of those is they often have some unpredictable effects. Now, this is something where I think I always want to take the time in the community, because especially parents of adolescents, it's, for those of you that work with adolescents or have adolescents, we know that sometimes they can be unpredictable as it is. They have mood swings. They have, they can be irritable. They can isolate. They can be erratic one day to the next. And so a lot of times it's like, how do I know if this is sort of normal teenage behavior, or if it's something I need to take a look at? So, and even substance use in the elderly population with prescription misuse or self-medication for some depressive circumstances, that's not uncommon either. So some things to look at. General signs of substance use disorders, and we'll get into the very specific diagnostic criteria, but when you're looking from an observational standpoint, neglecting personal hygiene, changes in physical appearance, weight loss, and poor grooming, those are some things to look for. Behavioral changes would be, this is a big one, increased secrecy, financial issues, absences from work or home, or even decreasing like the B+A student that all of a sudden starts getting C's and D's. And I think it's really important to point out that there's no one or two of these means that someone has a substance use disorder, and not everyone with a substance disorder is going to present with all of these. It's going to be a completely different constellation for each person. And what you really want to look for is you want to look for combined patterns of multiple ones of these that develop over time. Because if you look at this is, we're kind of just describing an adolescent that had to wake up early with a lot of these things. So emotional changes would be mood swings, irritability, general lack of interest in previously enjoyed activities. Some of those are actually a diagnostic criteria, which is that people are starting to sacrifice role responsibilities, whether that be student, employee, father, any of those types of things, in lieu of using substances with that time. So some specific signs for different substances. This is more like along the lines of intoxication. Alcohol is very commonly known as the slurred speech, the unsteady walk, and obviously the strong odor of alcohol. Opioids are going to look for those pinned pupils. It has a very sedative effect. People will it looks like they're struggling to stay awake. They might be nodding. They might have some slowed speech as well. Stimulants, that's going to be kind of the opposite. That's going to be with the very excessive energy, rapid speech, and also some perceptual or psychological changes, especially with something like methamphetamines, that could range from paranoia all the way up to a full-blown psychotic episode. So these are some of the warning signs of intoxication, and also just patterns of where substance use is becoming problematic. So in terms of, and as I mentioned before, someone may not look or act the way we expect someone with addiction to. This is extremely important for those of you who are tuning in to try and learn more because you maybe have some concerns about a friend or a loved one. Trust your instincts. And if you notice consistent changes in behavior, mood, or functioning, and this is what I'll say, you know your family members, we know our friends. These would be, what we want to look for is changes off baseline. If someone is just starting to kind of decline or take a radical departure from who and how you know them to usually be, look for some of those constellations of symptomatic presentations. And later on in the presentation, we'll go into a little bit of sort of what to do about that and what the options are. Now, I want to transition to the DSM. That's the Diagnostic Statistical Manual, the 5th edition. This is basically the manual that all mental health professionals use to make sure that when we say someone has depression or major depressive disorder, that we're all sort of talking about the same thing. If someone goes to the doctor and they have a cold or strep throat or something, you could take a culture, a blood sample, and you see the little germs running around. Their mental health, there's no blood test for depression necessarily, and to see little depressions running around in the blood or those types of things. So we rely on behavioral criteria over time to make sure that there's consistent diagnoses for these types of disorders, not just what it is, but also what it isn't. So that if someone is, because there's a big difference between someone who is situationally depressed or acting depressed or feeling depressed and someone with major depressive disorder. We need to be able to differentiate those. So what I'm going to do briefly is review what some of the diagnostic criteria for specifically for substance use disorder is. And when I'm speaking with my students, one of the things that we sort of point out is it doesn't necessarily have to do with the fact that they're using substances or the fact that they are using substances in increased quantities. When you look at this, there's 2 to 11 different criteria. Well, there's 11 different criteria. You need to have at least 2, right? And so 2 to 3 symptoms would be a mild substance use disorder, and it ranges up to severe, which would be 6+ symptoms. And they're clustered into 4 separate categories. So the first one would be impaired control. And what that means is this would be the example of someone who wakes up in the morning, they say, you know what, I'm done with this. I can't drink like this anymore, never again. And by 4 or 5 p.m., that now is kind of out the window, and they may already be intoxicated. And sort of what is that about? So when we see these things where people are using more than intended, someone starts out by saying, you know what, I'm only going to have one, and the next thing you know, they're blacked out. Repeated failed attempts to cut down or stop. A lot of what that looks like is someone says that there's like a bargaining stage sometimes. So like, I'm only going to drink on the weekends, and then by Wednesday, they're just like, well, it was a stressful week. Significant time spent obtaining, using, or recovering from the effects of substance use disorder. So if it's one of those things where it's like, that's taking up so much of my time. And then cravings. Cravings is a really important addition to that, because as we know with the DSM, it changes with each edition, and adding the cravings as a marker cravings are sort of those intrusive thoughts or physical cravings. And it's not like, hey, I could really go for a burger right now. I mean, these are strong, almost physical compulsions. It almost feels like trying to hold your breath. Sometimes the harder we try to resist it, the more intense it feels, and these can be a significant cause for relapse. And when we look at social impairment, we talked a little bit earlier about the role responsibilities at homework or school, continuing to use despite relationship issues, and then also giving up. When people start, they're not going to their hobbies, they're not playing their instrument, they're not going out with friends, and really the key is that with that time, they're staying home or they're isolating, mostly to focus on continued substance use. The last 2 categories would be risky use. So this is in physically hazardous situations, DUIs, going into neighborhoods or environments that are known to be risky, and doing it specific, foregoing that risk to obtain or use substances. And then the number one kind of observable behavior, I don't know if it's the number one, but one that I think can really kind of resonate with patients and family members as well, is just people continuing to use despite known persistent problems directly caused by continued use of the substance. These are patients that no one's really surprised, but it sort of turns into this, I know what, I'll figure it out later. And then the pharmacological indicators, these are incredibly important. Tolerance and withdrawal. Tolerance just means that I can't continue to use the same amount of the substance. Someone using the same amount of the substance, it doesn't do the same thing. Or I maybe need more to get the same effect. We're kind of talking about the same thing coming at it from different sides. So if, for example, one drink or one pill would get someone a euphoric effect or give them a buzz, and then one drink, over time, they barely feel it, or they're needing to have 2, 3, 4 drinks to really kind of get to that same level. The withdrawal symptoms are the other side of that. That's essentially what happens when someone stops or significantly reduces the intake of substance that they've become dependent on. I can give you a very quick example. Something like a benzo or an alcohol as a central nervous system depressant pushes down on central nervous system functioning, which is what gives it that sort of depressive, relaxing effect. And then the brain doesn't like that. Brain wants equilibrium, so it starts pushing back up against that. So it becomes this situation where it's like driving with your foot on the gas and the brakes at the same time. And so if someone were to abruptly stop, and the brain is used to pushing back against 5, 10 drinks a day, and those drinks don't show up, all of that extra energy kind of surges forward. And if you think about it, some of the first signs and symptoms of alcohol withdrawal would be sort of that tremor and all of that extra neurological activity where it can become dangerous. That's where the seizure comes from, is when that really kind of surges forward to a great degree. And again, for those of you who are either in the academic or medical communities, I'm aware that this is kind of a great oversimplification of some of these very complex neurological things, but for all intents and purposes, these are kind of the basics of how that works with withdrawal intolerance. Now, once it's diagnosed, we do want to look at treatment options. And the first stage, really, for someone that's become tissue dependent for the majority of substances, certainly the classifications of alcohol, opioids, and benzodiazepines. Those are the three that are really going to have either a radically uncomfortable physical withdrawal that can be treated, or a potentially dangerous withdrawal that can be treated. And so they would want to go through a withdrawal management. The idea of trying to sit through talk therapy or group therapy while going through these fairly horrific physical symptoms is just it's not plausible. So the idea of withdrawal management is it's a medical, like a medically managed, medically monitored type of a thing. It's usually an inpatient hospital stay. It requires a number of FDA medications and safety precautions and constant monitoring to make sure that the patients are as safe and comfortable as possible while their body is going through kind of this handbrake turn of adjusting to these changes, and providing analog substances or similar substances in a controlled way and reducing it over time. So that way it's more like a parachute than just dropping something right off the roof and wondering why it breaks. So this is critical for some of these severe withdrawal symptoms, as we mentioned. After that, there are a great number of options. And this is something that's very important to recognize, is that treatment really should be personalized. We'll talk about that shortly in a moment. But this idea that someone may need inpatient, someone using at a similar rate or whatever they may not. And a lot of what it depends on is there's a lot of different risk and protective factors that each individual patient is going to bring to the table. And really solid, quality, effective, and appropriate treatment should really address all of those different life domains, not just the biomedical. There's an emotional component to this. There is a cognitive thinking component, or there's social components, and to sort of just reinforce one wall of the bucket when there's holes in the other side of the bucket and then keep ladling effort into it, it doesn't make sense. So you really want these sort of holistic, person-centered, thoroughly assessed treatment plans when looking at that. And so inpatient rehabilitation is really for someone who has so much trouble maintaining sobriety in the environment that they really have a hard time going 24 to 48 hours without relapsing due to cravings or whatever other sufficiencies or life domain deficiencies they may have. So it provides a structured environment with a focus on this intensive treatment and stabilization. They're going to be consistently meeting with individual counselors, doing work on themselves, receiving therapy pretty much around the clock in a number of different modalities, as well as maybe some continued medications for some post-acute type things. So inpatient rehabilitation is really, it's a really good, viable option for someone who just has too many problems avoiding relapse in the community. So someone could go right from withdrawal management to inpatient. If someone is able to maintain their sobriety for 2, 3, 4 days at a time, but then really struggles, something like an outpatient treatment, it would start at like a partial hospitalization where someone's there kind of every day, usually from like 9 to 3. It's a big chunk of the day. And they're really there just building up those rudimentary coping skills, relapse prevention, impulse control, mood regulation, a lot of those types of the basics there, while still being able to then go home. And if they go home and they have issues, or they get, they kind of have to kind of white knuckle it a little bit until the next day, that all of those skills can be reinforced and re-upped. And then from there, that it just kind of steps down. You'd have an intensive outpatient, which is like 3 days a week. And then it can just move into outpatient, which that could be something like individual therapy once a week. And some people go through the full continuum where they'd start with a withdrawal management, attend an inpatient, then transition to some outpatient. Some people maybe skip around. Some people may be doing really well in an outpatient setting, and then they have a setback. There's a life change. There's a death in the family, or they lose a job, or their significant other decides they need a break or something like that. And if at some point they're their stressors exceed their coping skills that they've developed, they may relapse, and then they might return to a higher level of care and then work their way back down. Outside of some of these modalities, there's some other options. There's medication-assisted treatment. These are FDA-approved medications to treat opioid and alcohol use disorder. What they do is they work in a number of different ways. Methadone, most people are familiar with, that would attach to the receptor and give it a full effect. So it's what we call a full agonist. The difference is it's much longer acting. It doesn't have these big spikes and ups and downs. It's been very stigmatized. It is sort of becoming a little bit more accepted, but it's still very, very regulated and does require daily dosing. But it's one of the most studied and seen to have some of the highest efficacy. There's a synthetic that comes out called buprenorphine. Some of the brand names for that would be like Suboxone, Subutex, Sublocade. This is a partial agonist. So what that means is that's going to bind with the receptor, and it's going to give a partial effect and give kind of a ceiling effect. And the idea is that if those empty receptors and the lack of going from using a lot of opioids every day, then switching to now using none, if those empty receptors are sending those signals to the person and they're experiencing these deep cravings, being able to provide something for that receptor to work on that either is longer acting, that should get them through kind of the day until the next dose without feeling these cravings or the need to relapse, then that would be kind of the idea there. But they are still opioids, and they would need to be titrated down. Someone would be able to stop that. And then there's something called naltrexone, which is similar to basically the same type of chemical found in Narcan. It comes in a pill form or an injectable. That's an antagonist. What that does is that means that it's going to pull everything off the receptor and then bind to it, and it works like a blocker. So that kind of, think of it as like the tow truck that pulls the car out and then parks in that parking space so nothing else can really get there. So that would block some of the euphoric effects for alcohol and opioids. So these are, and there was a great question that came up that someone had asked, and another medical director that I had worked with that's very experienced in the field, and he gave an incredible answer. And what he had said was, he said, really looking at, because the question was, if someone is on these medications, are they really clean? And then, of course, they were using some of the stigmatizing language. And that's in some like 12-step and AA, and some very traditional people in recovery will say, you know, if you're on any kind of medication, if you're on any of these types of things, you're not really clean, you're not really sober. And the answer that this person gave was, he said, well, instead of looking at it like from an abstinence model, looking at it like, if this person is able to take these medications on a daily basis and still go to work, meet their role responsibilities, not have cravings, be able to engage in their hobbies and move through the world in their lives the way that they choose to, they no longer meet criteria for substance use disorder. So in that sense, that's a really interesting lens to look at this medication through. This really not stigmatizing, and it really kind of focuses on recovery and personal choice without sort of some of these abstinence-only models that might not work for everyone. The interventions that we use in the field are cognitive behavioral therapy. That really helps patients correlate their thoughts, their feelings, and behaviors, and understand that there are skills and methods and ways to learn how to change the thinking to actually self-regulate and result in reducing negative behaviors and increasing positive behaviors and reactions. It works across a number of different types of issues and disorders. It's very common. It's easy to learn. And it's a skill set that patients can practice and develop. And then motivational interviewing really is about helping patients address their ambivalence. If they're still kind of on the fence, if they're not sure, ambivalence in substance use disorder really addresses the person who's kind of going in between, like, I don't want the consequences anymore, but I don't know if I'm able to stop, and they really can kind of get stuck in the middle of the road like that. Motivational interviewing is a very specific modality, a therapeutic modality to engage with patients to help them resolve that internally. They come up with their own answers. It's non-directive, and these are evidence-based. And the other thing that's incredibly important about any treatment is having a personalized plan. We talked about how there are all of these different life domains affected by substance use disorder, and a really good and effective treatment plan needs to be agreed upon and formed collaboratively and really address all of these different areas. And that that definitely takes time, and it takes skilled and committed professionals to be able to really work with the patients to help identify these things and put these plans together. It's a critical, essential element to any type of formal treatment. Now, as far as support resources go, there's the traditional like Al-Anon. Everyone knows or has heard about like Alcoholics Anonymous. Al-Anon would be support in kind of that same 12-step mutual support group type of setting for friends, families, and loved ones, where the sort of their identified patient, they would go get their treatment at or they would go get their support at AA. Al-Anon would be to support the families, because this is something with the social and interpersonal components and all of these changes. It can be devastating to families and cause a lot of issues, especially when you consider the secrecy and the lack of the loss of trust, and a lot of the dynamics can just be very, very challenging. Nar-Anon it would be the same thing for narcotics. And then CRAFT, this is actually an evidence-based model that was developed. It's called Community Reinforcement and Family Training. The best way to think about CRAFT is helping family members set limits, improve their communication, learn how to disconnect from some of these frustrating cycles, move away from feeling helpless and hopeless about what's going on, and learn how to communicate in kind of an assertive way, return to their lives and what's important to them. And what they found is, because of the way this is executed, it has a tremendous secondary effect. If I'm remembering the statistic correctly, I think patients or clients whose family members have gone through and are applying the CRAFT model, it doesn't just benefit the family members because of the changes that they make in the way they're engaging with the patient or client. The client is actually 70% more successful in their treatment just because the families are now responding differently. So that's definitely something in the community. I can provide more information to that as well. If someone were interested in that, I believe it's in the references. So what recovery looks like, I want to transition a little bit more to that. And we've touched on a lot of these topics. It's a process. It's a journey of change, healing, personal growth. A lot of that I know may sound a little more on the spiritual rather than clinical end, but that's really the best way to describe it. It's not a linear process. It requires a tremendous amount of people changing the way they think, the way they feel about themselves, their social and logistical patterns, their friend group, how they define fun and family, and these things change over time. And in the beginning, when their brain is going through a lot of these radical changes, trying to restabilize, that can feel like trying to hit a moving target. And support is absolutely critical. And what worked and was fine yesterday in early recovery, it might not be the same today. And just from an observational standpoint, if this was easy, substance use disorder affects a lot of very capable, very intelligent people. Trust me, if it was easy, the majority of my patients would have figured it out by now. This is something where, and honestly, that could be one of the more damaging aspects of substance use disorder, is when patients have to watch themselves sort of ruining their relationships and acting against their character, and doing things they really kind of wish they didn't have to do. It can really erode someone's sense of self and confidence. You have a tremendous amount of guilt and shame. And so when we use words like healing, it truly is healing, because what that feels like inside can be devastating. And when you're looking at someone that then has some impaired coping skills and some cravings, someone's feeling a big surge of guilt and shame and has this radical emotional and spiritual discomfort. Of course, the brain is going to say, well, I have the solution to that. We're going to need to go numb out. And that's part of what makes early recovery such a steep slope. There's 4 pillars that SAMHSA, which is the Substance Abuse and Mental Health Association, defines kind of in their working definition of recovery. And what that looks like is kind of these pillars, where health, which would be managing disease, whether that's mental health or substance use disorder, or even physical health. A lot of substance use disorder at the level that we see it at can turn into a lot of downstream negative health effects. Getting back into primary care, eating right, sleep hygiene, making healthy choices, home, stable, safe housing is critical, whether that's at a residential program or a halfway house or Oxford House, but having a safe place to go through this very challenging work. Trying to do this on the street or couch surfing in a chaotic environment is just not practical. And having a sense of purpose is really just this idea of engaging in meaningful daily activities. There's an entire lens that a colleague of mine and I developed, which really talks about this idea that substance use, we always see that as the problem because that's where the consequences come from. But if you think about it, substance use in a lot of ways is more often than not can be a symptom of a greater problem, whether that's and that could be a lot of different sources. It could be something internal, it could be something environmental, it could be past trauma, it could be all of the above. But that's why when you do, one of the first things we do in treatment is take a really good history. We want to learn about the individuals. We want to learn about where they are, what's happened to them, how did we get here, what are the contributing factors, and then community, having those supportive relationships and a sense of belonging. We talk about how relapse is possible, but looking at that not as a failure, as long as it's processed properly and someone can learn from it and course correct, it can just be part of the process. And it, when we see patients that are like, look, I just want to go home and figure it out, or I'm just going to try willpower or something like that, it's very unlikely that someone is going to be able to process this in the early stages on their own without the appropriate types of supports. Now, for those of you, as we wrap up here, who are looking to try and engage with someone, these are incredibly intimidating conversations to try to have. And people with substance use disorder have really developed a very sophisticated set of defense mechanisms and avoidance strategies and explanations and explosive reactions. And it's just they as an end result, it becomes very, very difficult and uncomfortable to have some of these conversations. So these are a couple of tips to how to approach someone if you feel they may have substance use disorder. Make sure it's non-confrontational. All the evidence we know is that any type of confrontational is just going to increase resistance, shut down the communication, and even further discussions of it possibly. You want to be able to express concern without judgment. Simple phrases like, I'm worried about you. Use observational descriptions. I'm seeing this and this happen and I'm worried about you. How can I be there for you? What's going on? What help do you need? Ultimatums generally are just another form of resistance. It's a good way to get compliance, but not any type of commitment. And it generally sparks resentment and more rationalization. Making sure people feel understood. You don't want to blame or shame someone because that's going to really it's going to be gas on the fire for any type of cravings or sense of numbing out. Trust me, someone with active substance use disorder is probably doing an excessive job of beating themselves up or judging themselves with that. To get that externally now, they're just going to enhance their sense of helplessness or hopelessness. And it's challenging because when you're seeing people who maybe have broken commitments or promises or are struggling or have maybe lied, it's hard to be there and be supportive and not be angry and ventilate that anger. That's why some of those family supports are so important. And then encourage professional help. That's always the best way to do it. We go through in a lot of ways, years of training just to be able to have some of these conversations comfortably. We do it all day, every day. And that's why we're here. The altruism is really a big part of what drives a lot of us as professionals in the field. It's why we get up in the morning. So we are here to help. We want to help. And we're happy to have these conversations, as challenging as they are. I'm going to take a moment to just talk about our unit. The Recovery and Wellness Unit, it is a withdrawal management unit. It's a hospital-based unit, but we also provide group and individual therapy. As a hospital, we can also treat a lot of the comorbid medical conditions. So if someone needed physical therapy, occupational therapy, wound care, gastro, we had someone able to continue their chemo while they were on there working on this with us. We really want to make sure that we're able to provide that supportive environment as well. We have an amazing nursing ratio. A lot of our nurses are holistically trained as well to be able to provide mindfulness and those types of things. We use a multidisciplinary team, so our clinicians are duly licensed, like myself. They're licensed social worker and licensed certified alcohol and drug counselors. There's a wonderful integration with our team of the medical, social worker, and the addictions counseling to really create this specialized therapeutic environment. And we really want to make sure we're maintaining that motivation and engagement. We have designed our unit so that everyone on the staff can spend a lot of time with them. The feedback we're getting from community members, other treatment providers, and patients, most importantly, are saying that they really do feel like they haven't received this level or quality of care anywhere else. And what we're doing is we're building this unit. Valley's motto is care like no other, and we're really taking that to heart here in terms of how it's structured. And for a lot of us in the field that have worked for a number of other locations, we're really trying to take the best of what we've seen and trying to avoid any other mistakes that we've seen in the field, and just trying to create the most effective evidence-based type of practice that we can, because we know what the patients are looking for. We know what they respond to. And the most important thing that we do here, because it is a medical unit, is we focus the entire time that a patient is ready, willing, and able to just make sure that there's that transition to a personalized continuum of care. We talked about that before. If they need residential, if they need outpatient, we want to set them up for success once they leave withdrawal management with the support that they feel good about being adequate. So this is what we say: help is available. Our phone number is here. It's the 201-612-4949. We don't use a call center. They can get to speak to someone directly on our care team, and they'll get them started with the process. Our website has a lot of additional information. We have a blog on there. There's some videos. And then also I'd put the NJ crisis hotline in there, because obviously if someone really was deeply in crisis or suicidal or anything like that, I always want to make sure everyone has the New Jersey hotline. So at this point, that I know we've covered a tremendous amount of information in a short period of time. It was a fairly dense overview. I'd like to see what questions, if any, anyone from the audience has, and I'll do my best to answer them. And thank you, everyone, for having me and for your time tonight.
Thank you so much, Chris. That was really comprehensive and so interesting as well. I was wondering, what would be, I mean, I see there's a couple of numbers there, people to call, but what would you suggest to somebody who really feels that their loved one has an issue or a problem? What are maybe like the first steps they could take to help with that?
That's a great question. And that can be extremely complicated. I mean, for us, we deal with substance use disorder and its ins and outs and ups and downs all day. And I would say the best thing to do would be to get a consult from a professional. Tell them what you're seeing. Have someone, I mean, we can do screenings or consults. I can't tell you the number of times a family member would call our unit and say, listen, I think my XYZ, my son, my husband, my wife, my sister has a problem. I don't know what to do. And we have a structured screening that will go through and gather all the information that we have. And then we can walk them through helping them try and connect that person. And, if you offer someone a lot of the time, do you want treatment or do you want help with this? It's a big leap. It's a dumb example, but the other day I was in the dentist and they finished my cleaning and they said, hey, the doctor has a little bit of time. There's a cavity. You want to get that filled right now? I'm like, no. And it just was such an automatic reaction. Why would I want to do that when I could delay it? So jumping right into, hey, do you want to go to treatment? You may just kind of default to an automatic no. Now, what I will say is when someone's had enough, they will come to you and they will say, I can't do this anymore. I need your help. A lot of the times when we see this in the early stages, they're still trying to figure out, or they may kind of be negotiating with it to say, how can I kind of keep doing this and still juggle all my responsibilities? That's the toughest time to have that conversation sometimes, because they may want to stop, but they may also want to keep going at the same time. And it's like a tug of war internally. So someone in that sense, if you see, or it's suspected, or you know what you're looking at, you ask them, they tell you straight up no, and you want to say yes. The best thing to do is to encourage them to get some information. And that's where some of that supportive questioning that I asked before is, how can I support? Would you be willing to talk to someone to figure out if this really even is a problem? And that does a couple of things. It kind of sets up for the part of them that's maybe wanting to lean into it. Well, maybe it's not. It's the idea of, I might not want to go into treatment, but I might be open to get some more information. So that's what I would recommend. It really, like with so much in this, the short answer is it depends. But if they're not saying, hey, I want treatment, instead of offering treatment where you're probably going to know, just offer the idea, hey, would you be willing to at least get a little more information and see, like, is this a problem? How much of a problem is it? We're trained to have these conversations. We can help them navigate that and really kind of make a decision there.
Great. Thank you. And just finally, is for the person that's sort of fairly new to this addiction issue, whether it be a
Mhm.
family member
Mhm.
or somebody who is themselves struggling, um, is there any particular, I don't know, literature or book or place where somebody could get like sort of just basic information that makes sense to sort of learn more, knowledge is power that you would
So
recommend?
yeah, well, there's a, I heard the term the other day. It's an amazing term, and it's starting to emerge. It's this idea of someone who's sober curious. And
Yeah.
it's like, do I have a problem? Do I want to address the problem? Can I manage it? And it's exactly what you're talking about. I don't know what I'm looking at. How do I find some information without jumping in? There are in the county, there are a number of peer recovery centers, where these are, it's a certification level where someone who has um, experienced substance use disorder and achieved sustained recovery and gone through some additional training and certification to be able to share their lived experience in a therapeutic way. What's incredible about that is, if someone, it's not just me saying, not just being empathetic and saying, I think I understand where you're at, or I can imagine where you're at. This is someone going, I know where you're at because I was in that chair. And it's very easy to build very quick rapport and have a real actionable conversation with someone like that. The peer recovery centers are the ones where someone overdoses. They're called by the county bedside. There's a whole initiative called ORP, which is the opioid overdose response team, or program, and they would come bedside and they'd say, "Listen, I was in that bed. I know where you're at. Let me talk to you about some solutions. Talk to me about what you're thinking. How long has this been going on? Have you thought about stopping?" That's an option. Finding a provider that can do craft, reaching out to a professional and saying, where can I get more information? As far as a book, I mean, yeah, absolutely, there's books, but something like Al-Anon, most people, I think, a lot of times, they can get that. They can get that experience, or they can get that information experientially, and that adds such a curative factor to be able to meet with someone who we're like, to provide that hope, to provide that sense of connection. Substance use disorder makes people feel disconnected, not just the individual affected, but families feel disconnected from them. And being able to connect with other people in recovery, it has such a powerful curative factor. So could a book do it, provide the information? Absolutely. But it would be missing some of those other curative factors that I would encourage someone to engage in if you're going to be getting the same information anyway. So maybe seek a mutual help like an Al-Anon, or look at the craft thing, call a treatment provider, or look for a peer recovery center. Those would be my recommendations.
Great. I know going on